like I said, oh, got it. So the contents are looking at the components of the full blood count and then what red cell indices are. Then we'll look at microcytosis, normo and macrocytosis, look at a little bit at hemolysis, and then some practice questions. And there's some questions throughout as well. So essentially on your full blood count, you get these counts, a white blood cell count, the red blood cell count, and the platelets. And these are measured automatically through a counter. You get a measure of the HB and you get the hematocrit. Then you have these things which are called red cell indices, and they're actually calculated from the values up above here. And we'll go through them in a second. There's the MCV, mean corpuscular volume, MCH, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration. The RDW is the red cell distribution width, and we'll go through that shortly as well. And then what I was meant to ask you what the RDW is, but we're skipping that here. So the RDW looks at the range of cell sizes within the sample. So you can see this one, smear A, all the cells are the same size. So the RDW wouldn't be raised because they're all the same. So this is basically comparing the range from the smaller size to the bigger size. In this setting where you have small cells and big cells, this would have a raised RDW, and the term used to describe that is aneocytosis. You might remember the prefix aneo means irregular or uneven. When you have uneven pupils, you call it aneoscoria. So that's just to help you remember the Latin behind that. And here's a picture of aneocytosis at the bottom on a smear. You can see we got some big fat cells, so smaller ones and smaller ones. So you'd see an elevated RDW here. So that's a clue to that in the blood test before you see the smear. Looking at how we classify the anemia, we'd go off the World Health Organization, and you can see here for non-pregnant women, it's above 120 is what we use in Australia. Pregnant women, you go down to 110, and that's because of the plasma expansion that occurs in pregnancy. And for men, it's a little bit higher, 130. And then you grade that mild, moderate, and severe based on the World Health Organization classification. Now, so one of the features in the blood count is the hematocrit. And so you may wonder what I need to use that for. Hematocrit compares how many red blood cells are there in the total blood volume. So it's essentially showing you how concentrated it is. So one thing you can use the hematocrit for is actually determining if someone is dehydrated or fluid overloaded, because it's showing you the concentration. So if it's high, you know the person might be very dry, or if it's low, they may be very overloaded, such as liver failure, heart failure, renal failure. You might even use that to guide your diuresis in a way. So if you see the hematocrit is going down, you know that your diuresis is working, you're getting the patient drier. The other cause can be obviously anemia, because there's less red blood cells, and we'll go through all those causes, and polycythemia, which is an elevated red blood cell count, and that obviously would raise the concentration too. So it tends to correlate with those two things, but clinically, we typically use it to guide concentration. Great. So the red cell indices, which I mentioned before, we'll start with the mean cell volume. That's calculated by dividing the hematocrit by the red blood cell count. So again, all of these indices you can actually calculate with the first three numbers that you get in the full blood count if you want to do them yourself, but they're there for you. And it's expressed in femtoliters. Does anyone know what the normal range of the MCV is? Just off the top of their head. That's okay. Oh, I should check the chat. No, that's all right. So the normal range is 80 to 100. So it's easy to remember. If it's greater than 100, it's called macrocytosis. If it's less, it's called microcytosis. This is important because it helps us gauge the cause of anemia, which we'll go into later. The mean corpuscular volume comes next. This tells you actually the raw amount of hemoglobin that is inside each cell, and you can do it by dividing the HB by the red cell count. Now, unfortunately, this measure doesn't really add much because the bigger the cell is, the more hemoglobin it's going to have. So we already know what the size of the cell is. So we don't actually use this much clinically. That's why we have the extra number, the MCHC. So the MCHC again stands for mean cell hemoglobin concentration. And that's telling us how much hemoglobin is actually in each cell, controlling for cell size. And that's how we describe things as hypochromic, having a low amount of hemoglobin, or hyperchromic, having too much. So for all intents and purposes, just ignore the MCHC. It's in very advanced settings, you may use it to gauge things, but you don't need to know that unless you're a heme AT or a consultant. Just stick with the heme MCHC and know that if you want to call something hypochromic or hyperchromic, that's the value that you're looking for. And the range is from 32 to 36. Now, what are some causes of hyperchromia? So you can think, just to give you examples, remember this is showing you the concentration. So not only if there's low amounts of hemoglobin, if the cell itself is smaller, it's going to have a higher concentration of hemoglobin, right? So that's reasons why you may see hyperchromia. And there's a lot of quite relevant clinical conditions where this occurs, such as spherocytosis. You may have heard of hereditary spherocytosis. It's a red membrane disorder. Sickle cell disease, I'm sure you've heard of before. Schistocytes, these are helmet-shaped cells, which you can see in the middle here, which typically occur in intravascular hemolysis. So they're all clues of if you before you even see the smear, if you see hyperchromia, which is an elevated MCHC, that can clue you to one of these things going on. So one of the pearls to take home is if you ever have an elevated MCHC, you should always request a blood film or smear to identify if any one of these cells are here. And then the other thing to keep in mind, again, this is a bit more, what's the word, advanced, but you can take onto it now. Because the machine is automated, there can be errors in the machine that cause an elevated MCHC. So if you have an MCHC that's grossly elevated, we're talking like, 40, 50, 60, it's probably not real and it's something wrong with the machine. So you can see here in red cell agglutination, when the cells get stuck together, the machine's not able to identify that as separate cells. So it's going to tell you you've got one big fat cell with a lot of hemoglobin in there. But obviously that's not true. The cells are just stuck together. So some conditions where the high MCHC could be an artifact is lipemia, where the lipase is detected by the machine as red blood cells. Red cell agglutination, which you can see here. Leukocytosis, again, the machine may think the white cells are red cells. And hyperbilirubinemia is another thing. But that's quite advanced. Just remember, if you have a high one, get a film and look for these different cells. Great. And then this is just showing you how we can differentiate the different causes of anemia using those two values we had. So if we go starting with macrocytosis, which is a low MCV, less than 80, we can then add on, or not add on, but look further with the MCHC to help determine the cause. And typically the most common one is an iron deficiency anemia, where you get a small cell, microcytic, and a hyperchromic cell with low hemoglobin. There's some other causes, such as lead, sideroblastic anemia. Yeah, but the most common one by far is iron deficiency, and we'll talk about that in a second. Then normochromic is probably the next most common one, and that's your more congenital conditions like thalassemia, which is an important differential for microcytic anemia. So if someone may ask you, how am I going to differentiate whether this is iron deficiency or thalassemia? Two things you can do is, one, look at the MCHC, which will help you out, and also see if you can find other blood tests, because typically thalassemia will be present for a while because the person is born with that disorder. So that's all clues we can get from just the basic full blood count. And this is the same information, but reorganized to show the different causes and what those cells may look like. I thought I would just do a side about iron deficiency anemia, because that's the most common cause. And does anyone want to share any symptoms that they know of for iron deficiency anemia?
Fatigue.
Yeah, fantastic. Thank you. We've had someone drop out already at the thought of questions. It's okay. Any others? How about I ask Aaron? Any symptoms you can think of?
Like general pallor.
Yeah, awesome. Really good. And where might you see the
In the conjunctiva.
Yeah, well done. Beautiful. So you can see it obviously generally in the skin, but also the conjunctiva. Any other symptoms? Maybe Ella?
Palpitations.
Yeah, awesome. Really good. Great. Well done, guys. And so other things, just to remember shortness of breath on exertion, weakness, restless legs is a common cause. Iron deficiency is associated with that. So always check the iron levels in someone reporting restless legs. And then just generalized headache, fatigue, poor focus. Signs, we've touched on already. Someone mentioned the pallor. Other ones that we can see. So this is colonychia or spooning of your nails. So you can see it's got that dip. This here on the side. Can you see my mouse, by the way, guys? Maybe?
Yeah, we can see it. Yep.
Oh, beautiful. So this thing here on the edge is called angular stomatitis, and that's seen in iron deficiency anemia. Here you can see quite pale conjunctiva. And the thing on here is this glossitis, which you can see a loss of the demographic markings of the tongue. And then the other thing here, this is a good example of the low MCHC with these very hypochromic cells, so iron deficiency anemia. And the last thing to take home here is an acronym that I've used before in med school, TAILS, to help remember the cause of macrocytosis. So thalassemia, anemia of chronic disease, but this can be also normocytic, just remember, iron deficiency, lead poisoning, and sideroblastic. Great. We'll move on to normocytic anemia. And this one, typically, you want to first look at the reticulocytes. Now, remember, reticulocytes are not included on the standard full blood count, so you should ask for them to be added on. And they are basically juvenile red blood cells. So if you have, that's the main branching point for normocytic anemia. If you have an appropriate reticular response, then two causes are either hemolysis or bleeding. If there is an inappropriate reticular response, it suggests that there's organ dysfunction, and that can come from the bone marrow, where you have issues with production, so aplastic anemia, myelodysplastic syndrome, multiple myeloma, endocrine issues, so don't forget that the thyroid disorders and other endocrine organs can be a cause. The kidney creates EPO, erythropoietin, which generates red blood cell production. So in chronic kidney disease, you get a normocytic anemia and also liver disease. There's a little caveat here that shows in early iron or vitamin B12 deficiency. Now, typically iron, we just talked about, is microcytic, and B12 is typically macrocytic. But in early stages, you can have normocytic anemia, and eventually you'll develop those characteristic sizes. Great. And this is the next one, just helping differentiate the causes of macrocytic anemia. We tend to branch them first off as megaloblastic, which is related to vitamin B12 and folate deficiency, or non-megaloblastic. Important thing I want you to take home in this one again is reticulocytes. I don't know if I have another slide on this. Yes, I do. I'll go back to them in a sec. So lots of different causes. This is cold agglutinin disease. Causes the red cells to stick together, and the machine thinks they're bigger than they are. So if they report it as macrocytic. Having high sodium and high glucose in your body causes the cells to swell up and get reported as bigger. Liver disease is a common cause of macrocytosis you should be aware of. Not only just chronic liver disease, but having alcohol acutely can cause a macrocytosis. Some of the bone marrow issues, again, can cause macrocytosis. And remember, hypothyroidism is not common, but a key thing that you should always check for just by doing a TSH. But by far, megaloblastic is the most common. Now, reticulocytes, I mentioned earlier, are the juvenile immature red blood cells. They're actually bigger than the mature RBC. And so if you have reticulocytes in your sample, the machine isn't going to give you an elevated MCV because it's going to interpret you as having big red blood cells. So whenever you have a large elevated MCV, I think take home clinical pearl number 2 is reflexively just order a reticulocyte count, among other things, to make sure you rule out reticulocytosis, because that's important to differentiate. Great. And then here is just showing you some of the different patterns you could see on the blood film. We've talked about few already. Agglutination can occur. Rouleau is named after poker chips because it looks like that, stack of chips. Sickle cell, helmet or schistiocytes, spherocytes, we've talked about the small condensed, so they'd have a high MCV. And the chromia we've discussed as well. Remember, that's the low MCHC with not enough hemoglobin. Cool. How jolly bodies? That occurs in splenectomy or when you have functional or physical asplenia. Yeah, a lot of things to think about, but hopefully helpful. All right, so let's do this question first. A 55-year-old man presents with fatigue, lethargy, and reduced exercise tolerance. This is the full blood count. What condition could explain the test results? So does anyone want to quickly go through what's abnormal in this result? Maybe I'll ask Christopher.
So this patient's anemic, which is probably not a surprise for the tube, but it's macrocytic with a normal MCHC and a raised RDW and also a low platelet count. And the white cell count's normal.
Yeah.
So just going off, I guess, the macrocytosis, potentially cirrhosis and chronic liver disease as a cause, especially with a thrombocytopenia. You can get with the hypersplenism.
Beautiful. Nailed it. You said everything I want to say. So perfect. So a lot of clues here in the full blood count. One, we got the macrocytosis and also, as you mentioned, the thrombocytopenia, both from the pulmonary hypertension and shunting to the spleen, but also the liver generates TPO, which is the platelet generator. Remember we talked about EPO, erythropoietin. Thrombopoietin comes from the liver. So there's 2 causes why. Fantastic. Really well done, Chris. And so obviously iron deficiency would be microcytic. Chronic liver disease we talked about is typically normocytic, and aplastic anemia is typically normocytic. Great. Here is another one. So maybe, who haven't I asked? Maybe Isaac, do you want to go through? So this lady has got shortness of breath, dry cough, and fever. What's abnormal in her full blood count?
Yeah, so her hemoglobin is low, suggesting anemia. Hematocrit's also low. So that would be dilutional, possibly.
Yeah.
MCV's raised, so be
Macrocytic?
Yeah, macrocytic, yeah. And then MCHC is raised. So that would be megablastic.
Not megablastic, hyperchromic. Yeah.
Hyperchromic. Yeah.
Megablastic refers to macrocytosis caused by B12 or folate deficiency. That's all good. And of all those results, does any of them seem the most sus to you? What's like way out of here?
The MCHC.
Yeah, well done, dude. So a 66 is crazy. Like that doesn't seem normal to me because look at the normal value is 32 to 37. So something is going on. So whenever you have a raised MCHC that looks that bad, I would suggest you ask for a film. And this is actually, so 66 is sus. Do kids still say that? And so we should check the film. And this is what her film looked like. So it was sus. So does anyone want to describe what we're seeing here? I did mention it earlier in the lecture, see if anyone was listening.
Ella in the group chat saying agglutination.
Awesome. Well done, Ella. Yeah, so you can see all this agglutination here, and that's really what's explaining this blood result. So the HB is low because the machine is counting this as one big fat red blood cell. So there isn't many. The MCV is big because you've got all this joined up together, and the MCHC is high because this is not real life. Well, not real life. It's mistaking these as single cells. So this is a very difficult question. I'm not sure if someone will know this, but I'd be very impressed. Does anyone know a condition where you would present with cough, shortness of breath, and fever? So I'll give you another hint, a type of maybe pneumonia, but you get red cell agglutination.
I think like mycoplasma pneumonia
Well
is
done.
associated with cold
Beautiful.
agglutination disease.
Well done. Is it Gardner? Is that your name? That's fantastic. So, this is cold agglutinin syndrome. So what happens is that in colder temperature, these antibodies precipitate and cause agglutination like we're seeing here. It can be triggered by many things. It can be triggered by infection, and one of the key examples that they talk about is mycoplasma pneumonia. But other causes can be lymphoid and malignancy, and also autoimmune disorders. So typically what you would do if you saw that, you would see like the blood test that we saw. You'd also see evidence of hemolytic anemia because it causes cold hemolysis. You'd want to do a DAT test, a direct antigen test, to identify that there is hemolysis. And it typically will be CD mediated, so complement mediated. Warm hemolysis is mediated through IgG. So this will be negative. The complement will be positive. You'll have low complement as well. And then again, that characteristic thing on the blood smear. Great. So this is just, obviously you'll have these slides, you can read it in your own time. But again, so quite amazing. Just in the full blood count, we can diagnose what type of lung infection someone has just by looking at the full blood count alone. So I thought that's a pretty cool application. Great. More questions. So this is an elderly lady. She's home alone and she's got fatigue, reduced exercise tolerance, and 6 months of functional decline. She's no longer leaving the house, no longer shopping, cooking, or cleaning. And what is abnormal on her full blood count? Who have I asked? Maybe let's try Rivanya. Yeah. Okay, we're gonna try Kimia. I love an atlas.
No worries. Right, so the white blood cells are normal. Red blood cells are low with a low hemoglobin. So we have an anemia. The MCV is normal, so it's normochromic, and MCHC is quite low, so it's a microcytic.
Yeah.
Microcytic anemia. To be RDW, to be honest, I'm not too sure of the significance of that, but it's high. I can tell you that.
It's good. Well done. Very, very good. Just with your terminology, remember this one is normocytic, and this one we describe as hypochromic with the MCH.
Sorry.
No, don't apologize. That's perfect. Good interpretation. So we talked about some causes of normocytic anemia, but yeah, you're right to question why is the RDW elevated. So let us go on and look at her film, and maybe in the interest of time, I'll just say what we're seeing here. Maybe I'll ask someone. So does anyone want to know what any key features they can see on this film? That's probably a tricky question. Is there any fun? What about, let's try Carl. Carl, you look smart. I can't see you. Do you want to tell me what you can see on the blood film?
Yeah, I literally just joined. But I think like I see a neutrophil and all these possibly red cells or cells with no nucleus that you know that doesn't look very red.
Yeah, that's great. Excellent. So there are some hypochromic cells. Well done. Does anything look sus about this nucleus, this neutrophil?
Someone in the chat saying ring sideroblast and Howell Jolly bodies.
Yeah, there are. Yeah, definitely. So there are some Howell Jolly bodies. Good. I wouldn't call these ring sideroblasts. They have a different appearance. But what I was pointing at is for this hypersegmented neutrophil. So remember, the neutrophil typically has 2 to 3 segments. When you have megablastic anemia, which is B12 or folate deficiency, not only do you get macrocytosis, but you also get this thing here, which is called a hypersegmented neutrophil. So that's a key word to remember and always to look out for you in your exams. It's diagnostic. So the question here is, if you recall back, the MCV was normal, but I've just told you guys that B12 and folate deficiency causes a macrocytic anemia. So why in this situation has the MCV been reported as normal? Maybe we'll try Pranay.
Maybe it's just early in the process, as you said.
Yeah, could be. Yeah. That's one of the answers. Nice. And what about if I give you another hint that we have these hypochromic cells? What were they typically associated with that we talked about earlier?
Sorry, not sure. I think I
That's
joined
okay.
a bit late.
All good, mate. So this is actually a case of mixed deficiency. So remember, all the things I'm telling you may not apply in your situation because it's full of exceptions. But if you think about what's happening, it makes sense. This lady was home alone for 6 weeks not eating, so she's going to be iron deficient and B12 deficient. So she's got these hypochromic microcytic cells from her iron deficiency. She's also got big cells with her B12, and that is being interpreted as the aniocitosis because there's different sizes. And we already had a clue at that, remember, with the elevated RDW that we saw in the first blood test. So the machine is only going to give you the average. So because there is small cells and big cells, it's going to give you the average size and report it as normocytic. But then the clue that there was a difference is that the RDW was high. Yeah. So remember, there's always exceptions to the rules. Don't say, oh, it's a normocytic anemia. It can't be B12 deficiency because there could be multiple things going on. So the other pearl is there are mixed deficiencies that can occur. And we had a few clues here to help us identify that. These are tricky questions. You're all doing really, really good. But just some like take homes, never trust the values that you're getting because it's a machine that's just automating. Great. Now let's talk about hemolysis, 7:15. Who can tell me what we like to order in a hemolysis screen? Have I asked? Who am I asked? Maybe Matthew? Have I asked Matthew? If I have, you can say yes. No. Maddie is out of particular. How about, oh, there's someone called participant. Who's participant? Do you want to give us a go? No. I laugh reacting. All right, I'm just going to go back to the top and let's try Aaron again.
I'm only my first year, so I'm not really too familiar with all the different tests.
That's okay. Do you have any that you've heard of before or not really? It would be hard to know.
Yeah, nothing off the top of my head, sorry.
That's okay. No, don't apologize. This is all advanced stuff. How about Ella? Oh, someone was talking?
Yeah. Would it be, from my memory, it will be a full blood count with a blood film. You need a reticulocyte
Perfect, yeah.
count, LDH,
Awesome. Beautiful.
antigen test. I can't remember which one.
So it would just be the DAT, direct antigen test, formerly known as the Coombs test.
Yeah.
I think Coombs was maybe a Nazi, so we don't use his name anymore.
Fair enough.
Right. And there's only one more thing. Oh, go on.
I think in the setting of ICU, we care about like some electrolytes, especially potassium, and then haptoglobin, I think.
Very good. Haptoglobin, great. That's awesome. So FBC, reticulocyte count, remember it's not included in the standard full blood count, so you've got to add it, order it as well. LDH, so LDH lives inside the red blood cells. When the red blood cells pop, LDH is freely floating. Haptoglobin is an enzyme that gobbles up free-floating HB. So when you have hemolysis, it will try to clear it by gobbling it up. So your haptoglobin will go down in hemolysis. LDH up because it's released from the cell, haptoglobin down. DAT stands for direct what does it stand for? Direct antigen test. I should know that. Yeah, it is that. And that's looking for hemolysis. And then obviously the blood film, always you should get a blood film if you're worried about hemolysis. And you can see here the causes are quite broad. We've touched on a few. So remember in the DAT positive, it can either be autoimmune is the most common, and it'll be warm or cold or mixed. And we already touched on cold autoimmune anemia. And then there's the warm. Warm can be caused by, again, lympho or myeloproliferative disorders, but also blood-related transfusion disorders. And then looking at the DAT negative, you can divide it as extracorpuscular, which means it's happening outside of the cell, or intracorpuscular, which is telling you there's something wrong with the cell itself. So in intracorpuscular, it can be a HB problem, such as thalassemia. It can be a membrane problem, such as hereditary spherocytosis, ellipsiocytosis, or paroxysmal nocturnal hemoglobinuria, or it can be an enzyme issue, such as G6PD deficiency, which is the most common, or pyruvate kinase deficiency. All of these acronyms are written here, by the way, so you don't have to remember them. And then the extracorpuscular, so the red cell is fine, but something is happening to it to make it pop. There's the TMAs, which is the thrombotic microangiopathies, and they include TTP, HUS, and DIC. These can be quite fatal, so they're very important to recognize. MAHA is microangiopathic hemolytic anemias. Infection such as malaria, which is the one you'd see more commonly. Babiosis, I don't think we see much in Australia. Clostridium perfringens. Many words. Liver diseases and venoms. So actually at the Austin, they have a toxicology bed card. So we get all the snake bites. And I saw a guy that got tiger snake bite and he came in with very severe hemolytic anemia because of that. So quite fascinating. I wanted to talk about the TMAs because they are quite life-threatening and also quite exciting. So the TMAs is where you get basically uncontrolled thrombi formation and it blocks up the vessel. And then because there's the blockage of the vessel, when the red blood cells try to travel through, they get broken up, and that's what causes the hemolysis. So it can be quite serious because not only do you have consumption of your platelets by forming these clots, you also get destruction of your blood cells. So you get anemia, you get bleeding because of having no platelets, but you also get blockages because you've got these thrombi. So it's this awful or vicious cycle of clotting and bleeding, which can be fatal. One of the most important ones to recognize is TTP, because TTP has a mortality rate of 90%. And to treat it, you need to do urgent plasma exchange. So the most important MAHA or TMA to rule out is TTP. And that is diagnosed with a pentad of fever, anemia, which is microangiopathic. So you get the helmet cells, thrombocytopenia, having neurological findings, and renal failure. HUS stands for hemolytic uremic syndrome. It can occur after infection, such as Shiga toxin. So this is called Shiga toxin related, and atypical Hus can be caused by other infections. What have I written here? Yeah, so just remember ruling out TMA is important in hemolysis because TTP has such a high mortality, but they all do. Like things like DIC can be quite fatal, a high mortality. Yeah, pregnancy can be associated with DIC as well. So remember that in a pregnant lady presenting with anemia, a microcytic anemia, you want to rule out hemolysis. Great. All right, I think I've got some more questions now, which you guys have been loving. So nice and easy. You just got to tell me what's going on in the blood count. Maybe who haven't I tried? Maybe Indira, MD2.
Sure. So white cell hemoglobin's low, anemia, MCV high, macrocytic, RDW's high, 30, could be abnormally high.
Yeah. And the platelets are normal. That's right. You're doing really good.
But okay. Yeah, platelets normal.
Great. So I've written that there. Can't actually remember what I've got next. Let me see. Oh, okay. Now, what can you tell me that you can see on this film? So,
Is I think they're called helmet cells.
fantastic. Well done. So there's a very beautiful helmet cell or schistiocyte there. And then this arrow is just pointing a neutrophil, so you can ignore that. What does this big cell look like?
Hyperchromia. Is it a reticulocyte?
Yeah. Well done. Yeah, that's amazing. Second year, killing it. So remember, I told you once before that if you see macrocytosis, it could be reticulocytes as a cause. So you should always check that. So that's what we're seeing here. So I think I have that. Oh, great. So yeah, remember, reticulocytes are not included on your full blood count. So if you have macrocytosis, like we did in this setting with an elevated MCV, always add on the retics. And we were able to see it on the smear. So then we did some more investigations. So Chris, what is pertinent here that we can see?
So it looks like there's a raised AST and LDH and bilirubin with a low haptoglobin, so possibly consistent with hemolysis.
Beautiful, excellent. Great. So remember, if you go back to the original slide, I said hemolysis is typically a normocytic anemia, which it is. But if you have elevated reticulocytes, it's going to present as macrocytic. Yeah. So remember, you can't judge everything. So yeah, it's tricky. I think you're probably all wondering, well, I can't trust anything this dude said. But just remember that the numbers aren't always black and white. So keep an open mind. And so in that setting, the cause of her anemia was hemolysis, even though it was macrocytic. But if you check the retics, then you would have been open to that and figured it out. Nice.
Jason,
Great.
question.
Please, yeah.
Yeah, just quickly with the FBC, is there any value that helps you differentiate if it's megoblastic or normoblastic?
I'm not sure what the term normoblastic refers to, because typically we just say megoblastic, and that is just a term that describes B12 and folate deficiency. So if you had someone with macrocytosis, you should order folate and B12, and if either of them were low, you could diagnose megoblastic anemia. Was that your question? Or
that answers it. Yeah.
Beautiful. And now I've got some more We're doing great for timing. Well done, guys. So I've got some more just questions to burn through. So this is a 24-year-old who comes to the ED with paresthesia, so tingling in his hands or feet. There's also proprioception and vibration sense that's impaired in the hands and feet, and some weakness. Now he's been inhaling nitrous oxide for a while now, a few months. I think you guys call them NANGs. And the FBC has showed macrocytosis. So does anyone know what investigation next would help establish the diagnosis? This is quite a tricky question, so I'm just going to be open to all, but maybe a final year might have heard of this before.
B12 because
Awesome.
the interaction between the nitrous oxide and also the peripheral neuropathy that he has.
Stunning. Well done, Mark. So beautiful. Everyone listens to Mark. He's very wise. So don't do NANGs because NANGs actually cause the degeneration of your B12. So it causes you to have inactive B12, and low B12 causes degeneration of your spinal cord, specifically the dorsal column. And if you remember from neuroanatomy, the dorsal column is responsible for proprioception. So that patient had the gait disturbance and the ataxia. Yeah, so it also causes, because of the obviously having the low B12, it will cause macrocytosis. Now, I've seen young people in hospital that took too many NANGs and now they can't walk anymore. So just remember that, but it is relevant. It comes up in real life. So remember, nitrous oxide can cause low B12, and then obviously the consequences of that. And I believe I've got another picture here to show you some macrocytotic anemia. Macrocytotic, that's not the word. Macrocytic, sorry. Great. Oh, I just went on annotate mode. Great, another question here. So this person has a 27-year-old goes to the emergency department after collapsing. She is afebrile. She's got a heart rate of 100, rest rate of 20, and her blood pressure is low. It's 80 on 40. And the lab tests show that she's pregnant. Now we have a smear here. Which of the following is the most likely diagnosis? Maybe let's try Anna Bartos.
I'm also a baby MD1, so I'm not entirely sure.
That's okay. Any of those, do you recognize any shapes on this smear? That look a bit weird?
Definitely a few strange looking ones.
Yeah, maybe this one I'm circling. Do you remember, oops, sorry guys. Remember this, the helmet cell?
Yeah.
Yeah, perfect. So we're seeing evidence of hemolysis here. And so I'm thinking about what causes of hemolysis can occur in pregnancy. Another important pearl just to take home is that DIC can occur in pregnancy, and it can be very catastrophic. So looking at the evidence here, and then of these options, DIC is the most likely. And so there's many reasons why it can occur. So ectopic pregnancy, but also trauma and blood loss. And sepsis are other causes. But there's quite a few obstetric disasters that can cause DIC. So keep that in mind as well, of a young person who's pregnant coming with anemia. Great. This one, a 79.
Question.
Yes.
How do you recognize the DIC for that patient previously?
Yeah.
Because you wouldn't want to wait for the blood smear to start treating the DIC, I assume.
I guess you'd have to wait for it, unfortunately, but the blood smear can be done pretty much instantly because it's like man-made, not man-made, what am I saying? It's like just done by a person in the lab. And so obviously if you suspected DIC, you would order urgent coags and a full blood count and a blood smear, and it can be done rapidly if need be. Yeah.
Thanks.
And obviously the treatment of DIC is supportive, so you need to be guided by what the blood tests look like. So if she has low like fibrinogen, you need to supply fibrinogen. If the clotting factor is low, you support in that way, and obviously treat the underlying condition. Yeah, it's amazing what you can get done in emergencies. You can even get bone marrows in like AML if you need it really quickly. Great. Next one, a 7-year-old woman has been lethargic for 6 months. Her peripheral smear is shown. Which of the following findings is most likely to be present here? So this one is, I think, relatively easy. Are there any first years that want to volunteer for this one? I just said it's easy. We can work through it together. That's okay. I can pick a random. Maybe Isaac. I haven't heard from you in a while. So maybe what's most striking about these red blood cells on the smear?
Is it that that term that you use to describe the different variation of size?
Yeah, there's a bit of that there. You're right.
Yeah.
And what about if you just look at each cell? Does it look very red, or is there a bit of white in the middle?
So there's definitely white in the middle, so hypochromic.
Stunning, really good. So of those options I've given you, which one do you think fits that?
Oh, wow.
What happened there?
D.
D, yeah, really good. So no, sorry, that answer, that's not correct. Sorry. There's two parts here. Sorry, I've led you astray. So that is, remember the range for the MCHC is 32 to 36. So that is not hypochromic. But if you have someone with hypochromic and anemia, what might it also be associated with? So what were some of the causes of having hyperchromic anemia?
Was iron deficiency one of them?
Beautiful. Yeah, really good. And so extrapolate from that. If she's got iron deficiency, which I'll tell you she does, what else would we see?
What's the normal MCV again?
It's 80 to 100.
So B.
Yeah, awesome. Well done. So there is some variation in cell size, you're right, but there are definitely some small ones, like that one is quite small. And the hyperchromia is showing you that it's suggesting iron deficiency. And then of these options, this one would be the most fitting for having iron deficiency anemia. Really good. What time is it? Oh, 7:33. Maybe I will just skip this one because it's almost done. And then this is the last question, so we'll do this. So the HB is low, the MCV is normal, the platelets are also low, the calcium is high, and the LDH is high. Now, looking at the smear, does anyone want to describe what pattern is seen here? If you remember the term, maybe I'll ask Gardner.
It was like the poker chips, like the Rousselot or Rouleau or something.
Very good, Rouleau. Very, very good. So we're seeing Rouleau here. Are you aware of which one of these hematological conditions is associated with Rouleau in the smear?
No.
It's okay. Anyone know? Should open up to the room. You're probably all starving. What time is it? 7:34. All good. So this is multiple myeloma. So there's some clues here. Myeloma is also associated with the elevated calcium. It's also associated with renal impairment with the elevated creatinine, and you also get a high LDH. And Rouleau is characteristic of multiple myeloma. So remember, you probably learned the CRAB criteria recently. That's been expanded to include the SLIM CRAB criteria. And so there were a few clues there that this person had myeloma, but just also remember that Rouleau is seen in myeloma. Great, and that is my last slide. Sorry for going over time. That's my first time I've done this. Great. Any questions at all?
Maybe they've sent you like questions directly,
in the
Jason,
chat.
in the chat. Yeah.
Oh shit, there's a lot of them. B12. Thanks for the tour. I've got to go. No worries, Aaron. This was very high yield. Oh, there's no questions there. Great. All right. Thank you, everyone.
Thank you so much, Jason.
That's okay. Good luck with your exams. Enjoy your night. Have a good weekend.
Yep.
And I think that's it.